Welcome, everyone. We're going to give it a few minutes for all the participants, all the listeners to join on, and then we'll get it started. All right, welcome everyone to the 19th webinar that SpecialtyCare has put on, lessons learned on applying ECMO to severely ill COVID patients. It's going to be presented by Al Stammers. I'm going to go ahead and turn it over to Al.
Okay, just to remind individuals for these webinars to get your Category 1 points, please go ahead and stay logged in for 45 minutes and then complete the post-survey. Survey is very short, 3 questions, should be pretty easy to do. And then, of course, we're going to have a Q&A session. Luckily, we have all of our co-moderators are extremely ECMO intelligent, and it's great to have Aaron Nichols, who's our clinical ECMO coordinator in the Houston area and in the Southwest. We have Chelsea Capone, who is the Chief of Perfusion at Children's Hospital in Augusta, Georgia, Augusta Medical Center. And we have Shannon Barletti. Shannon was at Thomas Jefferson Hospital, works in the Philly area, and has been involved in a lot of the research and a lot of the ECMO that's been conducted at Thomas Jefferson. It's one of the busiest ECMO centers in the country. So please go ahead and use that Q&A session. The moderators will watch the questions. And then if you like one that's being posted, please go ahead and give it a thumbs up, and that'll bump it up to the top of the list. So as Aaron said, we're going to talk now about some of the experiences that have occurred on a national perspective across the United States. The objectives for tonight's session are to review the summary of the work that's been done in 61 hospitals across America. We'll look at some of the techniques and some of the changes that have occurred. We're 2 years since our first placement of a patient on ECMO, which occurred in mid-March of 20. Actually, tomorrow would be the 2-year anniversary of our first ECMO patient that had COVID-19 that was placed on. And we're going to look at the factors that may be affecting outcomes. And I realize many individuals on the webinar tonight have vast amount of experience in this, so we look forward to comments that all may have to help us understand some of the changes that we've seen. So to begin with the background, there's a tremendous amount of research on the use of ECMO in COVID. There's over 1,300 citations that have occurred, and that's pretty remarkable because 2 years ago there were none. There's a lot of heterogeneity. There's a lot of differences in outcomes. Most of these are cohort observational studies, very few randomized clinical trials that are done. They vary from single centers to multi-institutional registry with both matched and unmatched patients. And there are very few randomized controlled trials. So coming up with a causation is extremely difficult. And these two publications, I just used the general media to place them on, show the diversity. The one on the left talks about outcomes from a hospital that really had phenomenal outcomes, a phenomenal survivability with patients on ECMO. And if you look at their criteria, they had very, very strict criteria for putting people on ECMO, stricter than what ELSO recommends. And that, congratulations on the great results, but a lot of it is patient selection. And then on the very bottom was the Vanderbilt study that came out and said that most patients die waiting for COVID. This is obviously a very a very resource intense undertaking that hospitals had, and we all know that also recommended against starting ECMO centers in the middle of the pandemic. A little bit more data, 13,000 cases, 8,000 of them have been in North America. In-hospital mortality for the North American is about 48%. And if you look at some of the summary of what's going on with research that's been reported, about 0.2% of hospitalized COVID patients require ECMO at any time. There's a wide range in mortality, as already mentioned, due to a lot of features. I'm going to go over some of those a little bit. Mortality risk has increased steadily throughout the pandemic, and we'll look at that as well. But ECMO is recommended. It is something that has been shown to be very efficacious in patients that would otherwise surely have a very high mortality rate. What I'm going to do today, we've actually published 5 papers on this. We have several more that are in press right now. And we're going to go over some of that data from our own personal perspective and using our data analytics to try to track about why things occur that we're seeing and reporting on. So let's begin. The very first is a distribution curve. On the left-hand side of the screen, you see the states where ECMO centers that the information that we've gleaned is coming from. The stars that are shown in Texas, California, Florida, and Pennsylvania, these are sites that are doing more than 35 cases. And the distribution curve on the right-hand side shows the distribution of case number across our ECMO centers. And if we look at that a little bit more in depth and do an analysis, we find that there is a prediction that we could see with the number of cases, COVID cases. These are not total ECMO cases, although I'm sure the median would be very similar here. With the cases that are being done at institutions that are performing more have better outcomes in regards to survivability than those are doing less cases. This is also reported by ELSO. To look at the data itself, we have 138 patients that were placed on ECMO. 56 were transferred, and we don't have follow-up information on them. 682, therefore, were managed. And then we see that 58 are either still on ECMO or we have unknown outcomes on them. So when we start talking about the data and statistics, we'll talk about 624 cases, of which 240 were in the survivor category and 384 did not survive. Looking at the distribution across time, whenever you see a time chart like this, you'll see that the years are shown at the very bottom. As I mentioned, March 17th was our first patient, and most of this work was taken through the end of January. But you can see this sawtooth pattern. And if you went to go ahead and superimpose what was going on throughout the country at this particular time, we see these spikes that have occurred. The Delta variant hit in the third quarter of 2021, and then the Omicron variant hit towards the end of 2022. And so those were what we see in these phases that have occurred, these surges with the number of ECMO cases. And we all know right now there's a lot of discussion with Deltacron. The CDC has come out and stated that this seems to be a variant genetically of the Omicron and Delta combined. And it's unknown yet, although it's felt that it's not going to be quite as transmissible as either Delta or Omicron. Looking at the data, now these next several slides, I just want to point out, if you see this red rectangle that is around a particular variable, that's just trying to point out information on a slide. There's a lot of data, obviously, that we have over the past 2 years, and just to focus in on specific information, you see that red rectangle, just draw attention to that. So here we see that ARDS is the primary indication for support with these individuals. No surprise, COVID-19 primarily attacks pulmonary tissue, although of course multi-organ involvement occurs in a number of cases. And unfortunately, this is a male-centered disease that occurs. There's a number of reasons for this. If you look genetically at the immune capacity of women, women have much stronger immune capacity than men. And that tends to be some of the reasoning behind why less women are found, at least from a gender perspective. And then the age. In a few minutes, we'll show the transition that has occurred at age over time over the 2 years. from older patients now trending towards younger patients. In men, you can see here averaging about 4 years older than women who were placed on ECMO. If we group them by age, the majority of patients occurring somewhere between 30 and 59 years of age. And clearly shown this distribution curve over here, not so many in the older categories in the 60 and 70, and also in the younger categories. And we're going to talk a little bit about this in a second. And that's actually a good thing. We reported that if you look at the predicted probability using Bayesian type of statistics, the younger you are, the greater your chance of surviving the disease process on ECMO, as opposed to the older individuals who have a much lower chance of surviving the ECMO run. The distribution by ethnicity and race, this is primarily affecting the non-white community. Almost 70% of the patients that we see are not white, and with the primary group being Latino, and also African American shown at 15% of our cases. Now, this by itself may just indicate where our major ECMO centers are located. As I mentioned, they're in Southern California, Houston, Philadelphia, and also in Florida, in Southern Florida. So this may be something that just reflects the population density at those locations. As far as cannulation being an ARDS primary dysfunction, 91% of our cases are VV ECMO. And then as far as the cannulation use, 75% are used a dual lumen catheter. We have about approximately 25%, our single catheter placed in 2 locations is what I meant to say. And about 25% of the cannulation that is done is using a dual lumen technique with the distribution of crescent avalon and protect shown on the horizontal axis. If we look at the support time by cannulation type, we see that veno-venous ECMO, these patients are supported. This is mean and median by the color bar graphs. And the VV ECMO is on approximately 5 to 6 days longer than VA patients. And we look at mortality, VA patients, probably not a surprise to all of us on this call, have a mortality rate of approximately 80%, while the ARDS VV support is around 60%. The type of devices that are being used, CardioHelp is used in half of all procedures. And then we have approximately 35% that are using a Rotaflow Centromag or the LevaNova. Most of these devices are using the Quadrox technology, with just a few that are using non-Quadrox devices. I'm not aware of any that have been reported that used a microporous polypropylene oxygenator, although the FDA did clear those for use on an EUA perspective. As far as anticoagulation, I'm going to talk a little bit about this further in a few minutes when we compare the survivors and non-survivors. And we can see that 66% are using heparin. This is actually following ELSO standards, ELSO guidelines, which have come out twice, has said there's not enough information to go ahead and change your anticoagulation policies right now. So they're recommending that that does not occur, at least at the most recent publications. But then you can see direct thrombin inhibitors with bivalirudin or agatroban were used about 20% of the time. And then these other categories here show conversions. So we've had patients who have started on heparin and then either moved to bival or agatroban for a number of reasons. HIT suspecting adequate anticoagulation achieved with unfractionated heparin, or some other reasons. So we can see that we have this distribution occurring across the type of anticoagulants that are being used. If we look at this is another one of our studies, if you look at a grouping of patients that are non-COVID, on the left-hand side, this is just straightforward pulmonary dysfunction placed on COVID with an ARDS diagnosis. And on the right-hand side is COVID, 183 patients versus 392. One of the things that stand out is with direct thrombin use. And again, this is not a randomized controlled trial. This is just an observational study looking at the different techniques that are being employed across the country. We see that there's significantly more circuit changes with the DTI as shown in red, more hepatic failure, more renal failure, but there's no difference in mortality with either ARDS or COVID groups. but those same phenomena are seen with the COVID patients. Again, more circuit changes, more hepatic failure, and more renal failure with the use of DTIs. If we look at time frames, this is extremely important, and obviously from individuals who are determining whether or not to place a patient on ECMO with COVID, we see some very significant information that develops and has reached statistical significance. Again, the horizontal axis shows the distribution over the 2 years, ending in about January. And here we see that the time from diagnosis to intubation in days has increased steadily, peaked probably about mid of last year, June, July, and then it's come down slightly in regards to diagnosis to intubation. And as far as intubation to ECMO start, it's been pretty consistent, perhaps a slight dip that started in the 4 to 5 day range that has decreased to the 3-day range, with one perhaps outlier occurring in October of last year. But we see that there's probably been a slight declination in intubation to ECMO start time. So now let's talk about the differences between survivors and non-survivors in these two cohorts. As I mentioned, about 39% of the individuals who are off ECMO, 240 patients were in our survivor group, while 384 in the non-survivor. And if we look at those 384, 91% were not able to be weaned from ECMO. And then we have about 9% of the patients who were weaned and died more than 48 hours after the ECMO procedure, some actually dying a week to 2 afterwards. But the majority of patients were not able to be weaned from ECMO. If we look at why and what's the cause of mortality that's reported by each individual center, clearly the majority are failure to have any type of pulmonary improvement. And these individuals represent almost 50% of all deaths. And then the next 3 categories, multi-system organ failure, cardiac arrest, CNS injury, make up approximately 35% of the remainder. So close to 80% of the patients who died from one of these 4 categories. But we do have a fair number of individuals who both have hemorrhage and also sepsis. Looking at the distribution of when the deaths occurred over time, again, this really multiphasic type of distribution of deaths are shown. Primarily back in the winter of 2021 is where we see our highest summation of mortality occurring. And then we'll talk about what's occurring more frequently in just a second. If we start looking at the 2 patient populations, again, the red rectangles are just pointing out some of the changes, the differences that have been seen, both statistically and from an observation perspective. And the very first one is age. As mentioned and shown earlier, the older you are, unfortunately, the chances of survival decline. And then, of course, being male has a greater risk of dying. As far as distribution across ethnicities, not a big change here, other than showing non-whites make up about 73% of the non-survivors versus just under 70% in the survivor category. As far as the pre-Ecmo comorbidities, there were 7 that we looked at. And while there weren't differences that were seen individually by any of these, when you do a composite analysis and aggregate them into one group, we see that the individuals who did succumb had slightly more comorbid status with higher comorbidities than the non-survivor group. Looking at broad events that were occurring for these patients, both from a medicinal perspective and different interventions, we can see that the ones that really stand out were those patients who needed renal replacement therapy, higher group within the non-survivors. Not much different with medications, although we'll show some of those changes coming up in just a minute. And then finally, at the very bottom here, circuit changeouts. These are occurring in a third, if more than a third of all of our patients, whether you're a survivor or not. A lot of this is related to the time on ECMO. The time on ECMO for a COVID patient versus an ARDS patient can be up to 10 days longer. But once you control for that and place it into a statistical model, there still remains a statistically significant increase in circuit changeouts that's occurring related to the COVID disease state, regardless of the time on ECMO. And in the very bottom right here, this is just showing that some patients have 5, 6, or even 7 changeouts that are occurring with their entire circuit during the ECMO procedure. Cannulation survivability, veno-venous tends to have a better opportunity for individuals surviving versus the non-survivors. And then you could see similar distributions occurring in VA, VVA, and not enough patients supported VVV to really make a determination. As far as timing, as I mentioned earlier, time from CV diagnosis to intubation. Here's all categories shown on the far left, and we see that the timing is higher in the non-survivors. And then again, using statistical modeling, we see that the days between COVID diagnosis and intubation does have a positive relationship, so that if you have a quicker time period from diagnosis to intubation, your overall survival, chances of survivor are higher, at least predicted from a credible interval, versus those individuals that took longer from diagnosis to intubation. That was not seen, however, looking at intubation to cannulation. And you can see on the right-hand side, these days are very, very similar, only a half-day difference between survivors and non-survivors. So with these wide confidence intervals, here we can see that this probably wasn't something that was resulted in an increased chance of mortality. Looking at the length of support, individuals who are in the survivor category, again, mean and median shown by the 2 colors on the bar graphs, about 2 days shorter in regards to mean and 5 days by median. So individuals who are in the non-survivor category did have longer time periods on ECMO, which would make sense. Individuals perhaps less willing to give up the or to terminate ECMO for whatever reasons, either family related, limited chance of recovery, or whatever, some other catastrophic events occurring, hemorrhagic events, thromboses. We see that the time period is longer. And as far as tracheostomies, no real difference between the 2 groups, whether or not you received a tracheostomy or not. Unfortunately, in our database for quality improvement, we don't look at the timing of tracheostomy. It was a binary yes or no type of variable that we used. So there is research that shows earlier tracheostomy, and of course, more developing research that's saying perhaps don't even intubate patients, place them on ECMO, non-intubated would be something we should consider. Just a couple of tidbits, basic information that didn't really fit in a graphic format. Our longer survivor was supported for 128 days. We have still 1 patient on ECMO today and doing fairly well, who's been on for, as of today, 412 days. Our shortest time on ECMO was 2.4 days. And we have about 2.6%, just under 3% of patients who were off ECMO and then required a recannulation or reestablishment of ECMO. A small number were recannulated because of decannulation, but most were placed back on within 6 or 8 hours of termination. I mentioned anticoagulant use. If we look at the survivors versus non-survivors, slight differences in the use of the type of DTI and heparin. But if you look at the summation, if you had a heparin who was then transferred to an anticoagulant, a DTI, or either DTI, then we see that there are increases in the differences, in the categories of survivor versus non-survivor. And then looking at circuit changeouts, this was that other study that I mentioned, looking at ARDS pulmonary patients compared to COVID-19. We can see here that with the use of DTIs, that COVID-19 patients, regardless, had a higher change both with DTI and both with heparin. So COVID clearly is resulting with higher circuit dysfunctions. There's some controversy in the literature. Some people think it's related to just the time period on ECMO, but we have shown that once you take your data and control for these time periods on ECMO and the many different aspects of controlling, that it still remains an independent risk factor for circuit changeout. As far as discharge, now this is incomplete data. I only have data on 142 patients. Clearly, quite a few more were found. Unfortunately, a lot of these are lost to follow-up. But where patients are going, long-term care facility, the majority of individuals, other than the unknowns, 20% of those that are discharged were discharged home, rehab, back to our referring hospital, and on to lung transplant. And then on the right-hand side of this particular slide, we see that the time period for transfer, if you're going to rehab, it's averaging about 34 days as opposed to on to your referring hospital. Here, obviously we don't follow these patients once they're back to a facility that we don't have access to the information. So this number, although it's low at 18.7 days, is probably much higher and more similar to these other categories of where discharge summary occurred. Looking at the weaning successful, again, sequentially over the 24 months of the pandemic, you can see this pattern, which is difficult to identify, but we see this phenomena that has occurred once we fit that into a predictive model for survivability. We get this very high pattern that has occurred early on in the early phases of the pandemic. It dipped to its nadir in the middle of the pandemic, and this is days since cannulation. And then we see an improvement that has occurred over time. We corroborate the study that came out in Lancet using the ELSO data some time ago that showed this biphasic distribution with mortality. And actually looking forward, we think there's probably a triphasic aspect that we're seeing that has not been reported yet, but it seems to occur looking at the data, at least initially. Now, if you ask yourself, well, why is that occurring? What's going on that would cause this change in mortality? Most of us would predict, as we learned the mechanisms of managing these patients better within the intensive care unit, that we should see an improvement in overall quality. Well, that's not occurring, and this is shown both nationally and, of course, through the ELSO data as well as our own. But let's look at age. And as I mentioned earlier, the median age that we have right now is somewhere in the mid-40s. But look at the change that's occurring over time with individuals being younger that are now being placed on ECMO. And actually, if you look at also the distribution by ethnicity, we see that Latino group has really plummeted tremendously over the last 6 to 8 months with overall numbers, and more whites, or at least in the population that we're looking at, are being placed on ECMO. Again, the horizontal axis is months, so each one of these percentage points is an individual month. And then the African American population is also showing a similar decline to what we see with the Latino, dropping precipitously. So that's an interesting phenomena. And then now looking at medications, what's going on from a medicinal perspective or another intervention perspective. And we can see this distribution, this sawtooth pattern in regards to monoclonal antibodies that are used to block IL-6 receptors. And we can see that the distribution is occurring over time and changing. And why that occurs? Well, if you go ahead and superimpose some of the research that's being published, and those of you who follow research and the scientific distribution of information, this is an amazing thing that most of us have never seen within our lifetimes, where we see information that is being generated with such rapidity, and then it's being refuted. Once the data that comes out initially is usually observational, then a randomized controlled trial occurs, and then we see changes occurring in how these patients with COVID are being managed. And here's an example of that. This tocilizumab, which was presented in the New England Journal of Medicine at this time period here with this purple arrow, shown that once this paper that said there was really no benefit of this IL-6 receptor blocker occurring, you see the decline that occurred with the use. And then later on in the New England Journal of Medicine, this paper came out and said that actually these IL-6 receptor antagonists are actually beneficial. So you see this sawtooth response pattern within a particular medication that is occurring, which changes the how individuals are administering medications and other interventions, which we'll show in just a second. So something that, again, as I said, it's very rare to see this in medicine. Most of these type of studies take years to produce, and it just shows how the biomedical community is working so closely within the clinical community to change practice patterns at the most basic level. Other drugs that we've seen, the antimalarials, really very rarely shown anymore. It's interesting, in our patient population, we've seen some patients that are showing up with this, although the numbers are obviously have declined over the 2 years of the study. And then as far as steroids, most individuals now are receiving a steroid. And my feeling is if they haven't received a steroid, it's probably because they rapidly declined, got into the hospital, or they came from a referring hospital where for some reason on the EMR, it wasn't recorded that a steroid was used. The majority of patients, over 90% of them, the steroid that's being used is dexamethasone, with the next highest category really reduced to Solumedrol. As far as convalescent plasma use, remember how thrilling this was when this came out early on in the pandemic, and many patients received the transfusions. Unfortunately, it did not pan out to be as efficacious as individuals were hoping. And then somewhere in this time period, when this summary occurred, looking at a meta-analysis on the use of convalescent plasma, shown approximately here, most individuals have abandoned it, at least in COVID-19 individuals. Likewise, there was great hope with the use of filters that absorbed cytokines. With using these with this patient population, primarily because of the cytokine explosion, which is seen to occur. It's why IL-6 receptor antagonists were so heavily supported in regards to use. Unfortunately, there's not a lot of research on this. Some centers have used it and reported very good outcomes with it. Very few, if any, are randomized controlled trials. Again, mostly observational. But what we do see papers that are occurring, this critical care paper, which occurred, and this had shown that basically there wasn't a benefit of using cytosol filters, at least in this particular patient population. Another aspect of the disease process is unfortunately hitting women, pregnant women, and we have a number of those. 15% of our women, 33 out of 214 who were placed on ECMO were pregnant. And of those, 28 of them were postpartum. 11 of them had C-sections that had occurred. Unfortunately, fetal demise occurred in 3 patients, and then we had unknown outcomes in a number. We're very fortunate. There's a high survival in these individuals when they are supported on COVID. More recently, the last year, where we have information reported on vaccination, unfortunately, none of the individuals who were placed on since vaccination occurred had been vaccinated, at least that were reported to us. These are young women who were placed on. 32 years the median. Almost all of them were placed on VV support. The time periods, again, we talked about the importance of timing in regards to ECMO, and these were on for very short time periods. These patients tend to recover very quickly. Very quickly in regards to the COVID population. Normally, this would be a long ECMO run for a straightforward pulmonary population with ARDS. And then we can see that Latino population makes up about just over 40% of all these patients, followed closely by whites and blacks distributed here. So what are the unknowns? Clearly, there's a lot of unknown. There's so much research that's being done at this particular time. So many centers, either registries or individual centers, or groups like ours, are looking at trying to find out and learn and glean what useful information can occur. But there's a lot that's still unknown. You know, what is the effect of early extubation or omitting intubation altogether on these ECMO patients? I'm sure there's some on the call now that have experience with this and perhaps can comment on it. I know Aaron and Shannon both have experience with this. Timing and the need for tracheostomy. Just over half our patients were trach at some time period during their ECMO run. What do these timeline events mean? What is the significance of them? We all know that patients being placed on ECMO sooner than later result in improved outcomes, especially if they weren't managed for long periods of time on mechanically and then placed on ECMO. And then a selection criteria. We know that if you have highly selective criteria for the patient you're putting on, primarily to conserve resources and not use a blanket approach or an umbrella approach in putting everybody on, you're going to have better outcomes. Both ELSO says this, and the few studies that are single center that have also reported on this have shown us this. And then the cannulation technique, dual lumen versus a single cannula. So what are the take-home messages in conclusion? Well, we know that this requires complex pharmacological interventions. Although we reported on individual pharmacological strategies that were being used, the majority of these are combined and are used at various time periods with different dosing regimens. We know that true from a pharmacological perspective. Recent research has shown that perhaps we should be increasing our dose of bivalirudin if you're using a DTI above what is normally found, although ELSO does not recommend changes at this time. You're more likely to have circuit issues. Those individuals starting out early on in their careers with ECMO, normally if you're pre-pandemic, it's rare. Less than 10% of circuit complications require change out prior to the pandemic, now more than a third. So this is something you'll see more and more again, and probably requires us to use simulation and more adequate training for our ECMO specialists and individuals who are managing these patients. And as I mentioned, DTIs, there's weak scientific literature, very few randomized clinical trials. In fact, I believe only one that has occurred to date, although prior to this, before the pandemic, DTIs and the use of ECMO support was gaining popularity. So what is the take home? Survivors are more likely to be young and female, be supported with veno ECMO, and of course this means there's less multi-system organ involvement, and then have shorter times from diagnosis to cannulation, although from intubation to cannulation is probably not having a strong effect. And then finally, the last factor was have less pre-existing comorbidities, as shown by aggregate composite analyses of individuals presenting to ECMO. And that may be, of course, related to the timing with the younger patients who tend to have less risk of, say, obesity and also hypertension, which was one of the risk factors. So with that, I want to thank you for your attention. My email is shown here. I'd be very happy to discuss either via email or phone call any of this with anybody at any particular time. And I look forward to our question and answer session. Thank you.
All right. So looking at, if you have any questions, feel free to type them into the Q&A section on the bottom of the screen. Al, I'm going to start out with one. Referring to one of the first slides showed on the map of the United States, they were asking for the meaning of the slide. It was the one about the location of the patients. Is that correct?
Probably the map is what we put up at the district. Yeah, and that showed where our 61 ECMO centers are located. Again, this is registry data, just like ELSO. Not all centers who are performing ECMO belong to ELSO. So you're going to have a distribution of cases that are occurring across the United States, and it just happens to be those were 61. I believe we have 93 centers in specialty care that conduct ECMO, and of the 61 that have done a COVID case, that's where those locations were. So I'm not saying by any means this wasn't a CDC or Johns Hopkins type of distribution showing hotspots where outbreaks occurred. This is just the distribution of where the ECMO centers that are part of this analysis are located.
Thanks, Al. Our next question comes from Maureen Gray. She asks, within the group of change-out circuits, how many were using Tandem Life as the pump?
Wow, that's a very good question. And unfortunately, Maureen, I haven't looked at the data specifically to see what the distribution was by device. The fact that very few of our centers were using the Tandem Life, I would have to go back and look at that. But clearly, with 50% of our circuits being cardio help, it would be the majority would be shown there. But that's a great question, Maureen, and I will I will go back and look at that and contact you via email.
All right, we have a question here. Was BMI a predictor metric, and have we seen any differences with BMI?
Yeah, that's another excellent question. And obesity is one of the risk factors that we look at. And we did a separate analysis by obesity and using regression analysis and complex modeling, we did not find that obesity was related to overall survivability in ECMO patients. So although we know it's a risk factor, it's probably in combination with one of the other comorbid statuses that would cause an outcome that would be less than desirable. So it's a very good question, and a lot of people have looked at the fact of BMI. Now, one of the things that we did not do is we did not look at an overall distribution where we said individuals greater than 40, for example, what was the chance of them having a higher chance of mortality. I think it would probably be something most individuals would believe would be related, and there is some research to show that. In fact, it's one of the contraindications of placing individuals on ECMO is BMIs, and I believe most individuals do use the cutoff somewhere around 38 as being the highest that they would consider putting a patient on ECMO. So very good question, and we actually do have a paper that we published on that.
Thank you, Al. Now, there's a couple of questions about the Nautilus membrane. One asking that it showed one patient on a Nautilus. And I know we use the Nautilus membrane in Florida at the Tampa area a lot. Do you have any data on what other centers are using the Nautilus membrane?
Yeah, that's another good question. Obviously, it's a very good device, and it has seen an expansion in the use. Unfortunately, in our COVID population, we're not seeing a high utilization of it. As I mentioned, almost all of the centers are using the Quadrux, either in the cardio help or with an external pump. But in our general population, Nautilus, we're seeing the non-COVID is what I meant. We run the data set for our COVID patients, which are over 700 patients, and then we have an additional several thousand patients that we've looked at over the same time period. And so we're seeing that there is an increase in the Nautilus use, but we just don't have a lot of data on it now, but it is something that we will look at perhaps outside of COVID since it is being used more in our general population.
Someone asked a question about pregnant patients that are put on ECMO for COVID. They want to know, are there any changes in the anticoagulation strategy? And I want to further that with was there one type of cannulation method that was used over another?
Yeah, those are very good questions. And there have been a number of reports on pregnancy and COVID. Most of the reports that deal with pregnancy, COVID, and ECMO, they're doing it like us. It's a subcategory of individuals who are placed on ECMO. And the majority of our patients are postpartum, whether C-section or with the vaginal delivery. And those individuals have not had a change in their use of anticoagulants. There's not a higher DTI use, either argatromin or bivalirone, with those individuals, but that could be just the fact that they are beyond pregnancy at that individual. As far as the cannulation technique, no. The cannulation is still done with a distribution of the primary model being using 2 cannulas and a distribution of the single cannula technique. I don't want to quote off the top of my head because I haven't looked at the % use of that. I do have it, but I would be, I'd rather not state it because I would be more than likely off with the accuracy of that number. But we do have that information as well as the use of anticoagulation strategies.
Thank you, Al. We have a few folks here who have upliked a question. They say that they're somewhat surprised by the difference in circuit changes and organ dysfunction between the use of heparin and DTIs. They're wondering if all centers are standardized with what tests are being utilized for DTI anticoagulation.
Yeah, that's an excellent point. Most people use APTT is what they're using, and for the DTI, and we do have that. We have that information in regards to not only the coagulation assessment, but also in the range of tests, what they're using from a low degree of anticoagulation to high to, low to moderate to high. And we have that. The problem with this type of analyses, and to answer the question, when you control for those factors, you do still see, this is important, when you control for age, multiple factors that are associated with increased thrombotic potential and circuit issues, you still do see that COVID-19 by itself is strongly related, correlated to the need for circuit changeouts. And that's in contrast to what ELSO is saying. ELSO is saying that, no, it's just that these patients are on longer, and that if you just do a time frame, it's related to the time that they're on ECMO. Well, ourselves and others are not finding that to be true. That there's the relationship with the disease process itself and the multifactorial inflammatory elements that are causing the insidious nature of COVID infection to be related to the use of to circuit failures and problems that are occurring. So so to answer that question, I know I'm taking a long time to answer it. Yes, we absolutely do have the ability to look at the range in how the anticoagulation that is being given was administered in regards to its target ACT or APTT or 10A values. But there's a caveat there, because you all know, and I'd love to hear anybody, Shannon, Aaron, others, perhaps unfortunately we can't hear the people who were in the question area. I'd love to hear your comments, because if to state that, I went on and I maintained an anti-10A level or an ACT at this particular range, and that's what I put into the registry. We all know that variation occurs over time. We also measure the time off anticoagulation, and that's a variable as well. How long with a hemorrhagic concern or a bleeding diathesis that was occurring that you wanted to get ahead of, did you turn off the anticoagulant? And so it's so multifactorial to say, and I'm not implying by any means that DTIs are causing increased hepatic failure or renal failure, because we can't determine that. We look at those elements that are associated with why a DTI was being used. And in that one graph I showed on the horizontal axis where I said, okay, you started with bivalve, you started with argatroban, bivalve primarily, or then you switched, you started with heparin and went to bivalve, or it went to a DTI. Those are big differences, because clearly the change that has occurred was related to some clinical observation that would more than likely was a negative observation, HIT, excessive bleeding, heparin not working, heparin resistance that was developing. So you have all of those issues that were occurring that with studies like this that are multi-institutional with a wide range of individuals reporting, you just can't discern the exact reason. And that's why, as I mentioned, one of the big problems with all of COVID right now is the lack of randomized controlled trials. And when you don't have those, it's very hard to predict causation as opposed to something that just may be a commonality that you're seeing through observational research.
Great point, Al. Thank you.
Yeah. Next question, Al, is regarding the PCO2 level. The question is, has there been data that has been collected on the relationship between PCO2 level and survival, given that some centers have run PCO2 levels a little higher, allowing for some adaptation to get people off ECMO, and wondering if we have any data on that.
Yeah, that's another excellent point and great observation. We did track hypercapnia, as far as the diagnosis, ARDS plus hypercapnia, but we didn't track whether it was iatrogenic hypercapnia. If centers were iatrogenically, if the managing individuals, the intensivists, were letting CO2 levels rise, and whether or not that was done from a prophylactic perspective to improve outcomes. I'm going to embarrass Aaron and Shannon and Chelsea, but do either of the three of you have a comment on that, since our data just identified ARDS and hypercapnia, but we didn't ask the reason for the hypercapnia. Anybody want to comment on that from the three of you who are managing these patients?
Well, I'll start. Yeah, we've seen success in being able to do that, purposely letting it sit on the higher end of side, letting them adapt to be able to come off.
Interesting.
On to the next question. So Charles Johnson asked, did any of the centers use the CytoSorb filter during ECMO? And if they did, was morbidity and mortality decreased?
Yeah, and that's a great observation. What we had was several centers, one that used it almost on every patient, and then one or two that used it infrequently, which was more from an experimental perspective. And all the centers stopped using it except for one. And if you talk to the clinicians at those centers, especially the ECMO specialists or the perfusionists and the nursing team, they just reported on issues that they were having. Now, again, you really got to look at some of the research that is done primarily in sepsis and others on the CytoSorb filter, where conceptually and theoretically it makes perfect sense in these heightened cytokine type of responses to use a device that lowers the overall level and shows improvement in care. With COVID, it just hasn't proven out to be ultimately beneficial. Again, there are these reports that have shown reduction in circulating cytokines, and so they promote it as being beneficial. But when you look holistically and globally of what's being done across the entire ECMO community, there's just not a lot of use or support for its continued use, other than isolated centers who believe in it.
Thank you, Al.
Sure.
Next question, we're asking about the percentage, have we looked at all, the percentage of patients requiring CRRT and whether or not the CRRT circuit was integrated into the ECMO circuit? Is there any correlation between change out rates or survivability with whether or not the CRRT machine and circuit was integrated into the ECMO circuit?
Yeah, that's another really good observation. And what we do know is that individuals in the non-survivor group had higher uses of renal replacement therapy. So what does that mean? It's more questions being asked right there than not. So getting back to this specific question, was there a higher change out rate? There wasn't. We didn't see that the use of CRRT had promoted a individual risk for increased thrombosis due to circuit-related phenomena. But I tell you, it's a very good question that this individual is asking, and I'm going to do some search on this, because where the location of the circuit, where in the circuit it was located, would may have an effect on it. Although the individuals, I don't believe anybody is changing their anticoagulation strategy, either using a different type of anticoagulant or increasing the rate of anticoagulation or raising the target levels for the use of CRRT. I don't believe that's occurring, but it is a good point. And again, I don't mean to throw it all back at our moderators, but if anybody has specific information at their centers that they're knowledge of, I'd love to hear it.
We have had a significant number of our patients on CRRT. However, we do not integrate the CRRT circuit into our ECMO circuits at all, whether it's for COVID or our regular ECMO patients.
And to contrast that, all of our ECMOs, anytime that they are in need of CRRT, unless there's a trialysis catheter already placed, they're all integrated into our ECMO. And there hasn't been any difference in changeouts related to any of those patients.
Interesting.
Now, Aaron, do you adjust their anticoagulation management with that at all?
No, we still shoot for the same target. All right, so for the next question, the question is, has any of the data been broken down to separate those hospitals which are ECMO initiation only and then transferred to another center, or those hospitals who manage a patient from initiation throughout the run?
Oh, man, absolute great question. And we have that data. And the majority of individuals, 2/3 of all of the individuals who were placed on ECMO have been referred from an outside center. And I think that's important. I think that's really a critical part of the information that needs to be examined, because they're usually not sent. And again, I don't have this in our data set, but they're usually not sent the day they get the diagnosis. They're usually managed for a few days. And then once they see that, say, the PF ratio is declining, they say, we don't have an ECMO center here. We don't have an advanced ICU treatment, so they're sent out. So I say that more serendipitously than I say it with actual knowledge. But what we do have, and that's the question that this individual brought up, which I think is really valid, is the transferred individuals who come on ECMO. We do have that who came in. And I can tell you, although we haven't analyzed it in any of our models right now, those individuals who transferred don't tend to have a higher survivability, just looking at the raw data, not fitting it into a model, than individuals who were going out. Now, that's in contrast to most of what people have shown, that if you take individuals and send them to a referral center, an ECMO center that's primarily doing ECMO has been supported mainly in Europe and locally here in a number of states, they tend to do better. It's proven that they do better. But our data is, again, we didn't, it's not powered to look at that specifically, but we don't see that there's a big change in overall mortality that individuals who were sent to a center while on ECMO. It's a very good point.
Thank you, Al. I have two quick questions relating to equipment. The first one is there any consensus on signed the oxygenator? And then followed by, were hemoconcentrators used purely for volume removal or for interleukin removal as well?
The second question is, ultrafiltration that is being done on these individuals. It's mainly a renal replacement therapy that's being done. It's not like a standard ultrafiltrator that's used in say a non-COVID individuals, mainly because of renal dysfunction that is occurring in a fair number of individuals. So, and my thought is, we don't have a question on our data analysis that says, did you use an ultrafiltrator as a cytokine removal, or did you use it from a standpoint of volume taking off? And my feeling is that most of the individuals who are using CRRT are using it to maintain both renal function and also a volume removal, more so than cytokine. I think, the devices that are out there, although there is some literature to support that using an ultrafiltrator will reduce cytokines in ECMO, and this patient population, that's not been shown. And the first question was on the oxygenator. Chelsea, can you repeat that one? I'm sorry.
Yes, she was wondering, is there any consensus with signing the oxygenator?
Oh, with signing the oxygenator. Oh, that's
Yes.
a really good point. Yeah, and absolutely there is. And I'm going to ask Aaron and Shannon, who both sat multiple ECMO patients, to comment on that, since that's a very technical issue.
I don't know about Shannon's belief, but for signing the oxygenator, it is shown repeatedly that if that's not done, particularly on low flow oxygen levels, when you're talking about a sweep level of like 2 or below, the condensation buildup in those membranes can get really high, and it definitely impacts the efficiency of the membrane. We have repeatedly shown that when you get a obscure post-emo gas to go in there to dry it out, to side the membrane multiple times over the course of a few hours, and you'll see a dramatic shift in the efficiency.
All right. So Al, I know you can't see these questions or responses, but I would say so many of the questions are just comments saying what a great presentation this was and how much people enjoyed it. So I did want to pass that along to you, that so many people are just commenting on what great information this is. And I know you've worked tirelessly on all of this over the last 2 years. So thank you and kudos.
Thank you very much. Appreciate it.
Al, did you have time for one more question?
Sure, if that's okay. If we, I'll give a short answer. I won't give my New York long-winded answer, I promise.
All right. So there was a question about the use of the Protec and the Avalon. Do you have any data with the two different cannulations? Any data on the impact on the cardiac side or the pulmonary side in the use of those two cannulas?
No, and that's a great question, and that's something we will pursue. We didn't look at it, and we can look in the literature. We know a lot of people hesitate to use a dual lumen catheter, as shown by ours and others' research. Not that there's anything wrong with them, but just ease of placement and the requirements for placing those devices. But thank you for that point, because it is something we could look at.
All right. Well, that concludes this webinar. Thank you, Al, very, very much for your continuous work in this project. Thank you, Chelsea. Thank you, Shannon. Be sure to watch for the emails and for the advertisements for next month's Specialty Care webinar. It'll be on April 13th. It'll be a presentation from an intensivist point of view for ECMO from Dr. Irfan Khan. Thank you very much, and good luck out there on ECMO.
Thanks, everybody. Have a good night.
Thank you.
Thank you.